Well, good afternoon and good morning, everyone. We're excited to have you here for our third Igniter session. Today's topic is standard de-identified datasets, and we're pleased to have with us Kristin Paulson, who is the Chief Operating Officer of the Center for Improving Value in Healthcare out of Colorado. I would also like to remind everybody that our main conference sessions start next week. So if you haven't marked your calendars yet, you do so now for Tuesday, Wednesday, and Thursday of next week. And look at our agenda for some fabulous sessions. We have a lot of great content for you prepared and ready to go. Kristin's bio is available on screen. If you scroll down, you'll be able to see it a little bit farther down. And I'm just going to turn the time over to Kristin and ask her to introduce today's topic for us. Kristin?
Thanks, Norm. So we're here to talk about CIVHC's standard de-identified datasets. These are datasets that we created a couple years ago to really address some of the issues that we were seeing with our data. One, that we were seeing repeated asks for the same kinds of data. And two, those repeated asks were taking a relatively long time for us to execute on. And also the costs were prohibitive for a lot of people. And so we wanted to create a mechanism for us to be able to provide usable, valuable data to folks quickly, and while reducing the overall cost of the data and the way to access it. So we created these standard de-identified data sets. They're completely de-identified, so there's absolutely no identifiers in them, meaning that there's no HIPAA disclosure risk, which reduces any of the risk to CIVHC. And then we also went through and made sure to tailor these data sets to minimize any antitrust risk as well. We also, in these data sets, we included member and provider proxy IDs to allow for longitudinal analysis. And then built out 4 different levels. The 4 different levels are tailored to different levels of antitrust risk and are available to specific audiences. So we have level 1, 2A, 2B, and 3. And these are all available in 2-year increments starting from 2012 and have been run for commercial, Medicaid, and Medicare fee-for-service data. Because these are standardized and we don't have to create them for every single requester, we're actually able to produce these relatively affordably and within just a couple weeks of finalizing a data request through the organization. So I'm here to talk about that and sort of discuss what our process was.
Well, fantastic. Thank you. So where did you start? What were the first steps when figuring this all out?
So we started really trying to figure out what the sort of minimum entry level was going to be. We took our data element dictionary and we removed all of the individual identifiers and all of the elements that would pose a risk to antitrust. And that resulted in a data set that was completely de-identified, had no antitrust risk. HIPAA then didn't apply. And so it gave us our level 1 data set, which has no restrictions on who can use it other than you still have to qualify under Colorado's law and provide a benefit to Colorado. But it gave us a very broadly accessible data set that could be used by any number of different folks to support public health or to support whatever their project may be. And it was a low to no risk option for CIVHC. At that point, with that start in place, we then started thinking about different audiences. We went back to some of our previous requesters. We looked at the history of data sets that folks had requested from CIVHC and really grouped those together to try to figure out how we could maximize the utility of this while still keeping CIVHC's risks relatively low. And so we created then the levels 2A, 2B, and 3 to address the needs of specific kinds of requesters. And so those do have limitations on who can use them. In addition to the Colorado State sort of framework. So that was the very first step, was figuring out what we could include and how we could create value with these data sets.
So just to clarify then, so the level 1 data set, which is completely de-identified and just basically available to anybody who qualifies, you're not posting that on your website. People still have to contact you. And so you know who's getting a copy of that. And is there some sort of data use agreement that goes along with that?
Absolutely. The data is still subject to our data use agreement. And we do have requirements within the state. So every request that comes through Civic has to meet two different requirements. It has to in some way address the triple aim, and it has to have a tangible or identifiable benefit to Coloradans. And we do not consider contribution to the generalizable knowledge to be a specific enough benefit. So there actually has to be a way that this is going to benefit the state of Colorado. And so those pieces are still in place. This is not something we can post on the website. In addition, this is still a very, very large data set. So for example, the level 1 commercial data set is still, I believe it's between 2 and 3 gigs. So these are large data sets. They're too large to put on our website, and we do still have to have some control over how our data is used.
Good. So were there other specific considerations that you had to think about based on what the data or the nature of the data?
I don't think I can overemphasize how important the compliance piece was. We spent the vast bulk of our time trying to make sure that we were creating things that were as usable as possible while still providing that protection for Civic. So, compliance. We spent many hours sitting and going over things. We also went and, excuse me, we discussed and consulted with many outside entities as well. So we worked with our outside counsel, our outside antitrust counsel. We worked with local universities. We worked with some of our data requesters. And then, of course, it's had to go through the data release review committee, which is a statutorily required committee for the Colorado APCD. But the goal really was to make sure that we could address as many needs as possible with these more straightforward data sets. And then the other consideration really was usability. So when we went back and looked at what previous requests had included, what elements were they including that made these longer and more complex data requests, the number one element of PHI that was requested was dates of service. And we wanted this to be completely de-identified, so dates of service needed to be removed from the data set. And we wanted to really try to find a way to identify a mechanism to give people the utility of a date of service without actually having to have a date of service. So with our data manager or data partners, HSRI, we developed a sequencing algorithm that is applied to all of the de-identified data sets. And this allows for individuals to look at things like episodes of care, periods of follow-up, 30-day readmission rates, and things like that without actually anchoring anything to a specific date. And that allows us to have sort of a proxy for dates of service to increase the usability of these data sets. It's not a perfect proxy. We are constantly refining it. It doesn't meet the need in every single case, but I would say probably 75 to 80% of the folks who would normally be requesting dates of service are able to use the sequencing algorithm in its place.
Oh, great. Now, I think you've mentioned some of these already, but could you just maybe summarize the challenges that you encountered while trying to figure this all out and how you were able to overcome them? Can you just give us a recap of some of those?
Yeah, really the antitrust piece was the most concerning. I mean, that's our payers are our partners. The Colorado APCD does not exist without the collaboration and support of our payers. And so we wanted to make sure that there was not going to be any risk to them from an antitrust perspective by putting out these data sets. At the same time, we knew that those cost fields, those charge amount, negotiated amount, paid amount fields were critical for the usability of these data sets. So we really had to make sure, especially when we got past the level 1, that we were not creating an environment or creating a data set that could be problematic for our payer partners, for our providers, and other folks across Colorado. So we did create 2 different data sets. So the 2A is for our payers and the 2B is for providers. So they don't have a complete picture into all sides of the negotiation around those costs. And that limitation does mean that not everyone can use the data sets for what they want, but it is a safe place for folks to work without having to worry about the antitrust piece. The level 3 does include both payer and provider information, de-identified, but payer and provider information. And that is only for research use. So it's only for research use by individuals who have no affiliation with a payer or a provider in the project or in their day-to-day lives. So that antitrust was really the big challenge. We haven't had an update on the DOJ, FTC health data safe harbor for antitrust in 20, 25 years now. And so we're going off of a couple decades old guidance and trying to make sure that we have a safe harbor in place. So that was a lot of time with our outside attorneys and doing some really careful thinking and consulting to make sure that we had something usable but still safe.
And so in terms of usability, obviously the data is de-identified, but you mentioned being able to do episodes of care. So do you have some form of a hashed person identifier or a hashed provider identifier that allows you to construct that longitudinal data set?
We do. So the data sets include both a civic assigned member ID and a civic assigned provider ID for each member and partner. These are composite IDs, so we have collapsed all of the multiple versions of an individual's name into one. And then we're able to track those both across years, but also across payers. So in recent years where we're having folks that are churning on and off Medicaid, or maybe dropping from commercial onto Medicaid during the pandemic, we're able to track those as well. And we can also track the providers across that same, across distance, across systems, to be able to see any kind of changes in utilization or care provision. So yeah, both of those are individual de-identified member IDs.
So I've got one last question, and then we're going to start going to the audience questions. We've got a couple already in queue, but if anybody else has any other questions or comments, please load those into the chat and we will get to those. So my last question is then, so in terms of making the data usable, you mentioned making it a fast turnaround and also affordable. How is that going for you? Who is coming to you and asking about the data, and are you actually getting the use that you were anticipating from making this data available?
We are. We'd wanted to do these for several years, but didn't really have the space to be able to do the concentrated work on building them that we needed to do. But once they launched, they immediately became the fastest growing non-public release that we do. I believe they currently make up about a third of our non-public work, our non-public releases, because of the turnaround time and the usability. So we've got folks using these in research capacities all over the country. We've got local folks using these. I think our local school-based health system group is doing some work with one of these data sets to look at their reach and access and need in their communities. So yeah, we've had very significant uptake of these, and I think if anything else, I think if anything, it's only going to increase as we're able to start talking about, them in a wider to a wider audience. There we go.
Okay, great. Well, let's go ahead and take these questions from the audience. Charles, if you want to go ahead and put up the first one. So Mel asks, you mentioned de-identified, but are you including general demographic information such as gender, race, etc.? How do you identify this?
Yes. So for de-identified, we removed names, birth dates, dates of service, social security numbers, individual plan number. I mean, not the plan number, but individual insurance ID numbers, anything that was tied to a specific individual or a specific service that they received. So we still have gender, we still have race in there. We've got ethnicity, we have we have age in years. We can't do age, the specific DOB, but we have age in years so that you can do age bracketing. So all of this, Yeah, and we don't have any, so there's no zip in the level 1. Actually, I think in level 1, there's no zip code information. And the other 2, I think we have 3-digit zip. We really did want to keep these 2 very sort of safe, very safe, very low risk. So we did limit the geographic information. I'm trying to remember, we may have put something else. We may have put our division of insurance region in there as well, because that's large enough for us to be able to put in without triggering HIPAA. But yes, we have individual demographic information.
Okay, let's go to the next question. This one's from Carl. So Carl asks, let's see if we can get this on screen. What drove the decision around the years of data to be included? Because you'd mentioned putting these in 2-year chunks. So why 2 years? Why not 3? Why not 1? And what was the thinking behind that?
Well, we didn't want to do 1 because so many folks need to be looking at whatever their research question is something that happens over time, and we didn't want to limit that or it dramatically increase the cost just because they wanted to look at something over multiple years. We chose 2 years primarily based on our review of previous data requests. That was a very common time period that was requested, and it didn't make things too unwieldy for folks, because when we start getting to 3, 4, 5 years, for folks that don't have extensive experience working with databases of this size, it can get a little bit much. But we ultimately landed on 2 years. We actually are having a conversation as to whether or not we want to bump that up to 3. But right now they're sitting at 2-year iterations to allow for some of that longitudinal work to happen.
Okay, well, our next question is pretty straightforward, and maybe we should have covered this at the beginning, but tell us a little bit more about CIVHC's role. Are you a state or federal government agency, and what would be your relationship to the state government?
Sure. So CIVHC is a standalone nonprofit. We are 501c3 in the state of Colorado. That's actually required by our legislation. So the APCD statute in Colorado does require that it is administered by a non-governmental agency. That being said, the administration of the database, so who is administering the database, is selected by the executive director of our Department of Healthcare Policy and Financing, which holds our Medicaid agency and a number of other pieces. So we work very, very closely with the state. They are our number 1 partner. They provide the funding for us to be executing on those contracts and to be keeping some of our staff here. They're not our sole funder, but they are our biggest contract and our biggest client, and are definitely our priority when it comes to execution and work. But we are not part of the state government.
Okay, so it looks like we have time for one last question. So let's go ahead and put this last one up on the screen, Charles. This one's coming from Scott. As we know that there are 2 ways of determining that something is de-identified. There is the expert determination, and then there's a safe harbor. It sounds like that you went with safe harbor. Can you want to talk a little bit about why you decided to do that instead of the expert determination, and what difference does it really make?
Well, so I'm going to actually address that backwards. The difference it would make is that it would potentially allow us to include certain elements of PHI, like 5-digit zip, or certain dates of service, or what have you. We have always gone with the safe harbor method. That was a decision that was made when CIVHC and when the Colorado APCD launched, was that we were going to focus on using the safe harbor method. And that's what we've just used for the past 10 years. So there's no specific reason. We didn't actually decide that for the de-identified data sets. That's just been the CIVHC standard since we started hosting the data. It's certainly something that we are, always thinking through is, which way do we want to be going? And that may very well be something we change in the future. But right now, we are sticking with the safe harbor method, just from tradition mostly, but then also that additional safety layer.
All right. Well, thank you. I think our time is up. For those of you who are playing the NATO conference game, there is a token available. Let's go ahead and put that on the screen again, Charles, if you want to just pop that up. And we invite everybody to join us next Tuesday for our first conference sessions next Tuesday. So if you haven't checked out the agenda, make sure that you do that, and we'll join you next Tuesday. So thank you, Kristin, and thank you everyone for joining us. We'll see you next week.
Thank you.